Well, there's been a huge surge in the number of Ozempic prescriptions in Saskatchewan. It's traditionally a drug for diabetes, but has gained popularity for helping people lose weight. It's caught the attention of many people, including health policy analyst Stephen Lewis.
It's pretty remarkably effective. I mean, the typical weight loss in 1 year ranges from 10 to 20% of body mass. So if you weigh 250 pounds, a substantial number of people will lose 50 pounds, and most people will lose 25 to 30 pounds. So that's not trivial, especially since we know that diet and exercise, alas, are not very effective in the long term for most people. Most people who try to diet their way to weight loss end up gaining the weight back. The great majority do. So this is a potential game changer for weight loss.
And it is these drugs like Ozempic or Wegovy that help fight obesity, but they're rarely covered by drug plans, and there's a growing demand for that to change. So today on Blue Sky, we're going to learn about these drugs from people who take them, and we also want to hear from you. Are you taking a weight loss drug? If so, what difference, if any, has it made in your life? Should obesity be treated the same as other chronic conditions that require medication? You can call us right now, 1-800-716-2221. You can also email bluesky@cbc.ca. Well, our guests today have given this topic a lot of thought. Ian Patton is the Advocacy Director for Obesity Canada. Ian, welcome to Blue Sky.
Hi, thanks for having me.
And then we've got Hart Macklin as well, who runs a Facebook support group for Ozempic users. Both of our guests today are joining us via Google Meets. And so, Hart, welcome to Blue Sky.
Thank you very much. Yes, it's a Facebook forum for Canadian Ozempic and Wegovy users.
Okay, so let's start with your own experience with, is it Ozempic? What made you want to start taking it?
Yeah. Well, I started with something called Saxenda, which was before that, and it's a daily injection. It's still being sold. But after a while, when Ozempic came out, and they're both from the same company, Novo Nordisk, when Ozempic came out, I started to try that. And it worked better, and it's only once a week. So that's a solid medication that I saw results from almost immediately. I was one of the group of people who saw absolutely experienced a difference immediately.
How much of a difference? Describe it.
Well, as soon as I started using Saxenda and later Ozempic, I wasn't as hungry as I normally would be when those times came up. But even though I still got hungry, everybody does, the big difference is that I am satisfied with less. So where I would go to a restaurant and they would serve me a burger and fries and coleslaw and a drink, that would be a serving size for me, and that would make sense to me. I could sit down and I could eat all that, and I might even want dessert, who knows? But today, I can't do that. And almost immediately upon using the medications, I couldn't do that. So I cut my burger in half, and I often leave food on the plate. And I take less when I'm serving myself. The reality is that I feel full faster.
I'm wondering what it's like to experience that feeling, if that wasn't something that you had before. What's that like now?
Well, it's a complete change. It's unbelievable because you can be in a habit of eating whatever's in front of you. Like at Thanksgiving, you get in line, you get your food like the rest of the family, and you fill your plate because everything looks so good. But boy, when you start eating it, you get that signal from your stomach that says, okay, you've had enough. And that was good. Long before you've emptied your plate. That signal from your stomach is done by a hormone. And although my stomach was sending out that signal all along, the receptor in my brain was muting it. It wasn't hearing it as well. So the medication is really the hormone, and it floods my body with that hormone so that it's there all the time. And the receptor is always getting that message. But when I actually am full and my stomach is sending me more of that hormone, I really receive it. I receive that message, and now I'm absolutely able to stop eating, which
So
is remarkable.
yeah. So what is the physical difference that you've seen? Like I'm curious if we can maybe just back up a bit and
Sure.
to know that you wanted, that you needed this kind of intervention. Like where were you at physically, emotionally, all of that?
Yeah, I hate talking about that. That's the embarrassing part. But
Mm.
yeah, so I was actually a skinny kid up to 18, 19, 20 years old. I was in reasonably good condition, in reasonably good shape. I have pictures that show me as being a very skinny person. But somehow that all changed. It's a coincidence maybe that it happened at the same time that McDonald's opened up their drive-throughs. I don't know. But at the same time, I started to gain weight as I got older, and that happens to a lot of people. And I didn't know why it was happening. I wasn't able to give excuses. It just seemed perfectly natural. So starting weight was probably an adult weight was probably 160, 165. Breaking 200, that was a big deal. 250, I'm, I'm worried. And all along, I'm doing dieting and all the things that people try and fail at. And then when I hit 300, um, yeah, that was a moment because the scale didn't really work very well at 300 pounds. So then my brother, who happens to be a obesity doctor in Toronto, he recommended Saxenda, and I got a prescription from my doctor. And like I say, I immediately saw a difference. How did I see the difference? Again, I felt full upon eating a lot less food. And the things that were supposed to work in dieting actually did work. So drinking water helped. Um, and all the little things that people suggested, oh, just do this,
Hmm.
you'll do better. All those things started to actually work because I was having I was taking a medication that was helping me.
Yeah, and so often when we talk about weight and weight loss, the conversation steers towards willpower, right? And clearly, what you're
Right.
describing is that wasn't it. It was so much more than that. So how's your health now? If you're getting those signals from your brain that you're full, what has been the impact of that?
Well, there's been a lot of impacts. I mean, I'm certainly lost weight. I lost upwards almost 70 pounds, which is big. And I've got all my fat jeans and pants and suits still in the closet to, to demonstrate that difference. But I notice now that I can do things that other people take for granted, like going out to eat and not feeling like I'm eating too much. My wife and I like to go on cruises, and as the reputation is that on cruise ships, people eat 5, 6 times a day. But you know what? I went on a cruise. It was a 30-day cruise to Australia, and I didn't gain a pound in those 30 days. Matter of fact, I lost a little bit of weight because I did more exercise and more walking around. So the reality is that there's a lot of differences, and it's really been a fantastic experience. I wouldn't want to change anything.
So the group that you now run has, what did you say, 25,000 members?
25,000 members. Yeah, there's Canadians
Yeah.
and all over Canada, and they're seeking not just advice, but support. Because when you experience this, as I'm describing it, it feels almost like it's only you. But then when you reach out and you hear other people's experiences, then all of a sudden you're not so alone. And what you've been feeling isn't crazy. Well, maybe it is, but yeah, but it basically feels better to hear it from other people.
Do you ever get people who don't have a positive experience with the drugs? I just want to share with you a story of someone that we reached out to, that we connected with, and one of the drugs just didn't sit right. Let's take a listen.
This is Joe Gray. I was on Ozempic, and the after effects is what got me off of it. It did make me lose weight and help control my insulin a little better, but when I went back to where I was, it was the same. It never got worse, never got better. And with the Ozempic, I just couldn't take the pain.
Do you know anybody who's taking Ozempic just for the weight loss aspect of it?
A friend of mine, Linda, she took hers for weight loss, and she did good with it, and she was still on it. But she's taken something like Tums or something like that to kind of counteract the stomach problems.
I wonder if you hear about side effects at all, or people just not, feeling good about it.
No, for sure. I mean, there are some solid side effects. Nausea is one of the big ones. There's no question about that. Hey, look, constipation is a problem. Most of those are handled better through drinking more water. This medication absolutely for sure will dehydrate you. There's no question about it. And there's a reason why those people who seem more fit are walking around all the time with water bottles, because they've learned to drink more water all day long, and to drink water, not soft drinks, while they're having dinner or lunch or even breakfast. So the concept here is that the medication does cause dehydration. That's for sure. And often constipation, nausea, headaches, those side effects are really from just being dehydrated. I mean, most of us are borderline dehydrated without Ozempic. Now drinking more water solves that problem for a lot of people.
Yeah.
And the doctors aren't giving that advice out as easily because they're not the ones taking the medication.
We'll be talking more about the specifics of the medication and probably some of the side effects too when we talk more with Ian Patton, who's the Advocacy Director for Obesity Canada. But I just want to remind people that this is a really good opportunity to call us with questions. It might be a question that Hart can answer. It might be a question that we can put to Ian. Ozempic is getting a lot of attention. That tends to be the name that we know, but we also know that there's another drug called Wegovy. And so if you want to ask some questions, please feel free, 1-800-716-2221. You can also email us, bluesky@cbc.ca. Now, Hart, I want to move into the cost of the drug and the conversations that are taking place right now about whether or not it should be covered by a provincial drug plan. So first up, what does this cost you to be on this drug?
Well, I have good insurance, and I mean, that could change at any time, of course. So that is a problem that I worry about. But right now, I'm paying about $50 a month. So that's not bad. And frankly, I save that in food costs almost immediately. But other people are spending a lot more, the people who are paying for it out of pocket. And that's a real shame. There is, for diabetes purposes, some of the provinces are paying for it. But having diabetes too is, it isn't necessarily what you have from being obese. Sometimes you're obese because you have a problem with your blood sugars. And that was with me. I had slightly sweet blood, and that was causing me to become obese. Losing the weight, there's no question about it. My blood sugars are perfect. Now, in order to get covered by the province, I would have to go off the medication for a length of time and have problems with my blood sugars that weren't solved by other medications, and then apply for it. And I can't do that. I mean, that would be insane for my health.
And just for clarification, you're based in Manitoba, right? And so when you say
yes,
to reapply to the province to have it covered as a type 2 diabetes drug, you're talking about Manitoba. And there's, I think, slight differences, but, a fairly similar story no matter where you live in Canada. Just a couple more questions for you, Hart. So if it ever came to that, if you had to go off of it, and I should say, so $50 is what you pay, but a lot of people are paying more like $300 and some, right?
Right. I pay
Yeah.
80%. The insurance pays 80%,
Okay.
so you can do the math.
I wanted to clarify that too. Okay. So if it ever came to the point where you had to go off of it, what would happen to you physically? Like, what would be the impact of having to go off the drug?
Well, I'm sure that this ability to recognize when I'm full would slowly peter off. So I would want to eat more than I'm eating now at each sitting. And when I felt hungry and I had something to eat, I wouldn't feel satisfied quite as quickly. It would be a subtle thing, but it would definitely happen. And that would mean more calories, and that could definitely mean that I gain the weight back.
I'll just put out the numbers one more time here, 1-800-716-2221. You can also email us, bluesky@cbc.ca, if you have questions that you want to put to heart. But also our next guest, Ian Patton, is the Advocacy Director for Obesity Canada. Ian, you've been listening. I'm just wondering what your thoughts are as you hear Hart's story.
Yeah, a couple interesting pieces there that I think are worth digging into a little bit. Number one, I recognize the name, which so I know his brother here in Toronto, which is interesting.
Oh, okay.
There's a good video that your brother created that explains obesity as a chronic disease and how the brain heavily regulates weight and obesity. And so if you go onto YouTube, it's called The Gatekeeper, The Go-Getter, and The Sleepy Executive. And it is a fantastic explainer video that goes through and explains how the brain is heavily involved in obesity and weight management, and also would tie into how these medications work. So that was one thing that kind of jumped out at me. The other piece to this that I think I wanted to mention is we keep talking about Ozempic and Wegovy. I think it's important to understand that they are actually the same molecule. It's the same medication. So they're both semaglutide. That molecule has been approved by Health Canada for both diabetes management and obesity management. The issue has been in Canada, Wegovy, which is the obesity management version of the medication, has been approved since 2021, but we haven't had stock of it in Canada since last month. So for people who were hoping to utilize the medication for obesity management, it's been prescribed as Ozempic. So there's some nuance there to that discussion. It is actually the same medication. It is approved for both chronic diseases. And yeah, that's kind of.
I do want to ask you, though, about just how prevalent a lot of the advertising is for Ozempic. We're going to get into quite a few things, and we've got a whole other half hour to dig into this. But just on that note of, I think, the common name that we keep tossing about here is Ozempic, and there's a reason for that. There's huge billboards. Jimmy Kimmel made a joke about it at the Oscars. And so just wondering about that. It just seems to be so present in the zeitgeist right now, and we'll get into more of the reasons why. But do you see that too, that there's Ozempic just it's everywhere, it feels?
Yeah, absolutely. I think, I'm in the Toronto area. So right now you can't watch a Toronto Blue Jays game without seeing advertisements for these types of medications and things like that. It is everywhere. And there is a lot of attention, especially south of the border in the US. There's a lot of social media attention and stories that are coming up on it. You mentioned the Jimmy Kimmel joke, and there was recently a South Park episode focused on it, and Oprah has had some specials that were focused on these medications. So there's lots of pieces there to that puzzle, but it is getting a lot of attention for sure.
We'll get to Oprah in a second. So stay with us. We've got two guests with us today, Hart Macklin, who runs a Facebook support group for Canadian Ozempic users, and Ian Patton, who you were just hearing from, is the Advocacy Director for Obesity Canada. I'm Leisha Gravinsky. Today we're talking about weight loss drugs, and if you have questions, we'd love to hear from you. 1-800-716-2221. You can also email us, bluesky@cbc.ca. Ian, we were going through some of the numbers. So we have been able to establish that these drugs are quite popular. So here in Saskatchewan, over a 5-year period, Claims for Ozempic rose from about 5,700 in 2019 to nearly 195,000 claims last year, and about half of that would be for weight loss. So what do you make of that increase?
I think it speaks to the fact that it is an effective tool for people that have chronic disease that are looking for something that can help them. I think with all the attention we were talking about, there's going to be lots of people that are going to try the medication, but it does tend to filter out. As we mentioned earlier, there's some side effects. There's some people, it's not a magic medication. It's not something that's going to be the right choice for every single individual. But in obesity management, there hasn't been a lot of effective options up until recently. So now that we do have a few options and hopefully some more coming soon, I think you're going to see the usage of them kind of spike, like you mentioned, but they will level out and kind of fall to appropriate levels there, I believe.
How does a person go about getting these drugs? Like, I'm wondering about those first conversations with a doctor. Like, who's typically asking for information on these drugs?
So in 2020, Obesity Canada published the new clinical practice guidelines for obesity treatment. And since then, there was a lot of media attention about obesity and obesity treatments and things like that. So there are a number of physicians and health professionals that have gotten some training on these new medications and are up to date on this information. But to be honest with you, a lot of the push and asking about it has come from the bottom up. So it's been patients who are curious about it, who have heard about these tools that are available and are looking for effective supports.
So how do you determine who's a good fit for a weight loss drug?
That would be something that would be between the individual and their healthcare professional. So, in a lot of cases, there are some people that are lucky enough to have access to an obesity specialist, like Hart's brother in Toronto here. But there's few and far between across Canada. So in a lot of cases, that would fall onto primary care. So it'd be the primary care doctor who's responsible for obesity management. And just like any other chronic disease, you do an assessment, decide which would be the best approach, which tool is the best approach. And that's a very individualized path that they'd have to go down and figure out.
We're going to hear from Stephen Lewis, who's a health policy analyst, in just a moment, but he's going to bring up the fact that 30% of Canadian adults qualify as obese. That's a pretty huge number. Does that lines up with your thinking and the work that you do? 30% of people would qualify as obese.
Yeah, that's using the BMI classification as the measurement there, and the definition that we use in the clinical practice guidelines and that the scientific community is kind of shifting towards is that obesity is far more than just someone's weight or BMI. It's a lot more complicated than that. So the BMI classification is an oversimplification. So when we say that there's 30%, yes, based on BMI. But if we are looking at actual prevalence of obesity as a chronic disease, as outlined in this clinical practice guidelines, we actually do not have any proper tracking of that data or prevalence number. So it would likely be a little bit less.
So if not BMI, what would be a better indicator for who would be a good candidate for these drugs? What is the framework that doctors have to work with right now?
So in the clinical practice guidelines, there's a whole chapter on assessment and looking at these things. And so you take into account a few different things. The definition of obesity is it is a complex, progressive, relapsing chronic disease where excess or abnormal adipose tissue or fat tissue impairs health. And so you got to look at that health impairment piece as a physician when you're assessing things. So if someone has excess weight or higher BMI with health impairments and things that are there, there's markers through blood work and things like that they can include into that equation. there's a couple different measurements that could be added into that, but it usually includes that health impairment piece.
Because I think what I'm really wondering is, could anyone just go to their doctor? They could say, I feel like I've really struggled with the last 30 pounds, or 40, 30, 20. But that's not enough. That's not what this is not who the drug is meant to serve. If there's no other health indicators that show that weight is an issue.
Yeah, these are serious medications for a serious chronic disease. They are not an aesthetic medication. And I know there has been some attention, the Jimmy Kimmel joke that you mentioned, that's one of those things. Down in the States, there has been a lot of that narrative about people using it for more aesthetic purposes. But that's not what these medications are for. And up here in Canada, it is a little bit more difficult to get access to it, and it shouldn't be used in that way.
Okay. We may come back to that side of it in a bit, but we've got a couple of callers waiting on the line. So let's go to Kevin in Saskatoon. Hi, Kevin.
Hi. I don't want to put a damper on the pharmaceutical industry that's selling this stuff, but I'm living proof. In the last 4 weeks, I've lost 50 pounds, and I just changed my diet. It's garbage in, garbage out. I went to a strictly carnivore diet, and I've never felt better. A lot of my symptoms have disappeared almost completely. There is an over-reliance on quick fixes in society. Cut your carbs out. Cut your carbs out. It makes it real simple. You cut your pasta out.
Push away from the table.
Out, you eat.
Walk more.
It's not even about push.
Push away from the table.
It's a life.
Willpower.
It's a life. It's a lifestyle choice, and we've got too many. You walk down any, you name it, Costco, grocery stores, anything, Walmarts. They are full of processed junk. We're full of vegetable-based, modified oils that are no good. The body can't even digest them. I've done my research on it, and it all came. And I mean, I don't take my word for it. I don't have a PhD behind my name, but at the end of the day, you rely on the experts that are out there that have plainly disputed anything that's needed in terms of pharmaceutical application, and all it is diet.
Ian, I want you to jump in there, because I think this is exactly what we're trying to unpack and maybe challenge a bit. So when you hear some of the comments that Kevin just made, how do you engage with that?
Yeah, I mean, I'm glad Kevin found something that works for him, and that's fantastic anecdotal evidence. It's something that I can tell you is not bore out in the evidence. So we know that diet and exercise as a form of obesity treatment is overall ineffective. It just doesn't work. And that's because it is, again, an oversimplification of a very complex chronic disease. We're not talking about simple eat less, move more. It has not worked historically. It will not work going forward. He made some great comments about the food environment and some other things. There are pieces there. And I'm not saying that personal responsibility is not part of the equation. Personal health behaviors are absolutely part of the equation. I'm a kinesiologist by training. So physical activity and exercise, I fully understand the importance of physical activity and exercise. I've taught nutrition at college. I fully understand how important that is for overall health and well-being. But when we are talking about a actual chronic disease, which obesity is, it is not a treatment in and of itself. And so, there's lots of people who've, I've lost 50 pounds on more than several occasions. And I can tell you that it comes back when there's reasons why it comes back. And it's not all willpower. It's not as simple as, changing, to a carnivore diet or cutting out the carbs. I think you got to look a little bit deeper. There's a reason why those things don't work in general in the evidence, and why very, very few people who do what Kevin did are able to maintain that in the long term. And it's because there's biological, physiological, environmental, genetic components to this chronic disease.
Ian, this is a good segue. I want to ask you about bariatric surgery because I'm wondering, a lot of people who may have seen that as a solution to what they were dealing with health-wise is now weight loss drugs. Is that helping people avoid bariatric surgery? And I know you've got personal experience with this that we'll get to too, but in general, is this steering people in a different direction and now they don't necessarily have to get bariatric surgery, which can be quite invasive, right?
Yes and no. So, I mean, it's another tool in the toolbox. These medications are another tool in the toolbox. And as you mentioned earlier, the effectiveness that you see with these medications is approaching what we see with, bariatric surgery. One doesn't replace the other. There's going to be people for which bariatric surgery is the best choice. There's going to be people that medications are a better choice. And there's going to be people that might end up using both of these tools at some point in their journey because it's a chronic disease and it's going to take a lifelong time to manage it. So there might be people who utilize both. So I don't think we'll get to a point where we see bariatric surgery as obsolete. But I think having more choices is definitely beneficial.
Do you mind telling us a bit more about you, Ian? Because you've had bariatric surgery.
Yep. So I ended up having bariatric surgery in 2014. So I'm almost 10 years out from my bariatric surgery. And it was one of those things where I got to the point in my health where I was concerned about being around for my kids and my family. And I needed to do something. The things I had done before and tried to do over and over again hadn't worked, and I needed support. And at that time, bariatric surgery was kind of the gold standard. And I went down that path. So I went and had bariatric surgery, and it was life-changing. No regrets on my part for that. And I now happily talk about my experience with that.
Okay. We're going to hear from Stephen Lewis, and we're going to talk more about the cost of these drugs, both, the personal cost that people might be shelling out right now, and then looking at the calls for having it covered under a provincial drug plan. But I want to just go to one of our callers who's just joined us right now. So Lloyd in Frogview. Hello, Lloyd.
Yes, it's Broadview. Sorry.
Oh, Broadview.
Yes.
Well,
yes.
that I know Broadview, but I'm surprised by town names all the time. So there we go. Lloyd in Broadview.
Yes.
What made you call the show today?
Yes. Well, I called the show because I work in a grocery store and I watch what people buy, and I would like to throw this idea out: who's doing the work into? We talked. One of your guests gave the statistic that almost a third, or maybe more, depending which measure is used, of people are considered obese. What about looking at how much medications people are taking for this, that, and everything else? Because I think, of course, activity and sports is important, but I don't think it's the be-all and end-all. And yes, I think diet is even more important. What the person's eating. There's so much processed food that's empty and all the bad oils, etc. And that, I think, is even more of a critical issue. But I think if I had a special superhero ray gun, I'd like to see the customers that come through there, because without a doubt, everybody that's over 50 is on some kind of a medication. And I really think what's happening ultimately, people's metabolic system is being screwed up, and there's something that's wrong with their hormones and that's only partly from the diet and also by the side effects of the medicines. And I really don't agree with your guests there by taking another medication that's going to give us a magic solution. I think we have to really bore down why so many people, if there's 1/3 considered obese, then there's a whole bunch of other people that are borderline. This is more than just an eating problem. There's
Ian?
some other things. I'd like to see what your guests think about that.
Sure. Yeah. Thanks for calling, Lloyd. Ian, what do you say to that?
Yeah, that's some interesting comments. There's definitely a component to what both of those callers had said about the food environment, the food that is available, and what we have access to, and those sorts of things. The piece about medications and other medications that people are taking and how that can impact, that's something I'm less sure of. But the last little piece that he commented on there about, disagreeing that, we should be giving people another medication. I want to be very clear. I do not think that obesity medication should be given out to every single person who has obesity. But I will say that for people like myself, if I didn't have access to evidence based, effective obesity treatment, I would not be here today and I wouldn't be around for my children. So I disagree wholeheartedly. I think for people who have chronic disease, we should treat them with every effective evidence based tool that we have at our disposal. And that's not going to be for everyone, and that's fine. But for the people who need it, who it can be benefit to, that's fantastic. I get pushback a lot of times when I talk about my experiences with both bariatric surgery and medications, and some people will kind of talk about it as being cheating or taking the easy way out.
Mm-hmm.
And it's such a simple viewpoint of again, a very complex disease. You wouldn't say that about anyone with any other chronic disease. And when it comes down to it, when it comes to my health and being around for my children and being productive for society and being able to, have the function in my body that I need or that I want to live the life that I want, I will absolutely take a medication if that is going to help me do what I need to do. And this one has.
So what Oprah says, it's just way more complicated than a lot of people realize when it comes to dealing with this. Hart, you've been listening, you've heard all the calls, and so I just want to give you a moment to chime in here. When you and I'm sure this is not the first time that you've heard this kind of pushback to the route that you've taken. And so, Hart, how do you engage with some of that? Yeah,
for sure. And not only have I heard it from people who don't have problems and can just say, okay, well, my pants feel a little tight so this week, so I'll just cut back a little bit and everything will be fine in a week or so. And those people exist, and that's fine for them. But they can't be possibly thinking that their experience is the same as everybody else. All of us on this planet are unique and have all kinds of other issues, medical issues that need medical help. The problem is that what those two callers expressed is what I think 70 to 80% of the doctors out there think the same way. And they're basically looking at an obese patient and saying, well, maybe you should eat just less chickens and stop going to McDonald's and whatever. And it's just bad advice, and it doesn't work, and it harms the patient, which they're not supposed to do.
I want to just take the conversation in a slightly different direction and get back to some of the policy challenges that will come up with, just this major increase in the number of people taking it, and then again getting into some of the private insurance coverage and is there another way. So I want to get back to Stephen Lewis, who we first heard from at the start of the show. He is a health policy analyst, and at the start he was talking about how effective this drug has been for helping some people lose weight, as we've heard from both of our guests, but that they weren't able to do it with diet and exercise alone. But he says it opens up some policy challenges.
Since it is effective, and if it proves to be effective in the long run, and it proves not to have any debilitating side effects that would caution its use, it would be the second best treatment to bariatric surgery, which remains the most effective approach to losing a lot of weight and keeping the weight off. Of course, it's highly invasive, it's very expensive, but once it's done, it does generally work very well. So then what do you do? If you and your primary care provider or specialist say, your weight is a real health risk for you, and if you can lose a certain amount of weight, we know pretty definitively that very, very large excess weight, and whether we want to define obesity as the cutoff. But if you're carrying around far too much weight, your risks of just about every chronic condition go up. So it's a very good thing, all else equal, to lose quite a bit of that weight if you're one of the now 30% or so of Canadian adults who, in the body mass index definition, would qualify as obese. Well, that's a huge number. And if you could actually reduce that number significantly and reduce it permanently over the long haul, these people will be healthier and they will use the healthcare system less for serious conditions, or at least defer their use of the healthcare system for serious conditions. So when you look at it in a cost benefit perspective, it could be a long-term winner. Given the numbers of people involved, they could literally be in the millions. The cost of covering the drug publicly for either all or some of these people will be very high. But it's not an enormously expensive drug compared to some other medications for other conditions. It's about $300 a month right now if you paid it all by yourself. And presumably you might be able to negotiate if it's a national or a provincial approach to bulk purchasing. You might even get it for less over time. So $300 a month is $3,600 a year. It's not trivially cheap, but given the potential benefits and how effective it is compared to a great many other drugs, it's not terribly expensive, but it's expensive because of the numbers of people potentially who might use that drug.
So that's Stephen Lewis, who's a health policy analyst, and he did crunch some numbers for us.
Let's take Saskatchewan. So Saskatchewan has 1.2 million people, adults probably 900,000. So let's say a third, which seems to be the data, 300,000 people are significantly overweight, major overweight. Well, if a half of those people are interested in taking this drug and their providers really think they should, well, 150,000 times $3,000 a year is $450 million, right? $450 million is a lot of money. So where it does get tricky is, again, if it were a few people, it's a no-brainer. You just do it, right? I mean, it's so effective. And for a few people, you're not going to spend hundreds of millions of dollars. You would just do it. The issue here is that the potential number of people taking it is so big that it has to make an enormous dent in your budget. And $400 and some million, even if you could somehow negotiate it to half that, $225 million or something for one new drug looks daunting to a provincial budget, and particularly the health budget, and particularly the pharmacare budget. Private insurers are also in this game, right? I mean, we don't have a universal pharmacare program. So the reality is the provincial share of this would still be quite modest because most people do not, in fact, have public coverage in Canada. Canada has among the lowest rates of public coverage in the OECD. Only about 49% of prescription drugs are publicly financed, and it will vary from province to province. So private insurers are in this game. They probably are more inclined to cover it because they're often employer-sponsored, right? And employers would say, gee, if I have less sick time, if I have fewer people leaving the workforce because they've managed to lose the weight, that's a big win for us.
So that's Stephen Lewis, who's a health policy analyst. Ian, Patton, and Hart, I want to put this question to you both. Should these drugs be covered by provinces if they're being used for weight loss? Ian, what do you think?
I mean, simple answer, yes. And I think you got to look at it under the scope of it being a chronic disease. Are there other chronic diseases that we don't cover effective evidence-based medications for? And there's not many that come to mind. I think what we need to take into consideration, there are some significant costs, and he outlined those actually very well there. But there's also a cost of inaction. So there is a cost of not treating obesity, and that significantly will outweigh the cost of actual treatment. And I'm not saying that the amount of people that need to be on or should be on medications is going to be as high as he suggested. I don't know if that many people, it would be the right choice for all of those people. But I think for a good chunk of them, it should be accessible. And that's not the case that we have right now.
Okay. Hart, I'll give you just 10 seconds to weigh in yes or no whether or not you think it should be covered by the provinces. But then I have another question. So first off, just what are your thoughts on that?
I agree with Ian. Ian covered it. Did a great job.
Okay.
That's
then my
5
question
seconds.
my question for you comes from Heather, and we only have about 30 seconds. What resources were available for psychological support, and what do your callers think about the need for this support to be successful? So I'm just wondering, you've talked about how complicated this is. This drug helps change the brain, I guess, in the most simple terms. But did you get psychological support, Hart, to move through and all of that?
I didn't get psychological support because most of the people that I spoke to back in 2016 when I started this part of the journey, they had no idea about the medication. They knew less about obesity treatment than I did. I knew more. And so basically, I was unable to find any support. Despite that my brother is in the business, he lives in Toronto. But I spoke to him on a regular basis.
Ian, is this part of a holistic plan to help people with things like diet and exercise in addition to the weight loss drug, any kind of emotional support that they might need as they move through this?
Yeah. So the clinical practice guidelines have 3 pillars of obesity treatment. So we talked about bariatric surgery and pharmacotherapy. The other pillar of obesity treatment is actually psychological intervention.
Okay. We have to end it there because we're right at the end of the show. And as you can hear, I could have gone on for another hour, but I wanted to get that piece in there. And time to thank you both. So Ian Patton, thank you. And Hart, big thanks to you too. That was Hart Macklin. I'm Alicia Gravinsky. This is Blue Sky. We're back again tomorrow.